Howdy everybody, I'm Barrett with BarrettIndependent.com in today for RefugeMedical.com. This is episode 4 of the March algorithm and TCCC, Tactical Combat Casualty Care. I want to reiterate that this is information, not instruction. Please come to class. Whether it's our class or any other good trauma medicine provider's class, you need to do this stuff with your own two hands to develop the muscle memory, the automaticity to know how to do it. My goal here is to provide you with the information that you need to make informed decisions about how to put together a kit or what kit to buy, and the information to understand what's happening with some of the methodologies of these injuries. But you have to go train. RefugeTraining.com. We have training across the nation. Please check it out. Please go get trained. You need to know this stuff. It's much like having a rifle that isn't zeroed, it doesn't matter, okay? So, today we're gonna talk about airway and respiratory, episode 4, airway and respiratory. And we're gonna use our friend here, the leg. We have a simulated gunshot wound here, okay? We have an in-hole, we have an in-hole and we have an out-hole. So, airway and respiratory. March is massive bleeding, airway, respiratory, circulation, head injury and hypothermia, and then everything else. And so that's the March algorithm, which is based upon recommendations from the Tactical Combat Casualty Care Committee, COTC, based upon 20 years of experience in the global war on terror. EMS, fire, law enforcement, public servants generally are taught the ABCs. Airway, breathing, circulation. And as we've discussed previously, the issue with focusing on the airway first is the reason we need a patent airway, we need air to flow into the lungs, is so that we can oxygenate the blood. Blood is an oxygen delivery system. That's why circulation is so important. So that we can oxygenate all of our muscles and our internal organs and the brain, like super important. But if we get a patent airway first, while blood is leaking out of the body, it doesn't matter how much oxygen we get into the body. And so that's why March was developed. We deal with the massive hemorrhage first, the massive bleeding first, and then we worry about airway and respiration. And so airway specifically means this area of our face, this maxillofacial region here, our nose and our mouth. Air needs to be able to go into it, and we need to be able to expel carbon dioxide out of it. Respirations, breathing. So typically, what we're going to use to maintain a patent airway is this is called a nasopharyngeal airway. This is size 28 French, which is approximately the size that one would require for an adult. The intricacies of this particular medical device are covered in our classes at RefugeTraining.com. Responder 1, Responder 2, definitely Responder 3. The way this works, this is also known as a nose noodle, okay? EMS, they have what are called J-tubes or oropharyngeal airways, and it's a little J-shaped plastic tube that's inserted into the mouth orally. That works on unconscious patients only. It doesn't work on conscious patients because it induces the gag reflex. And so if you're conscious with the J-tube in, you'll try and cough it up, meaning you no longer have a patent airway. The nasopharyngeal airway can be used on conscious and unconscious patients. And it goes up the nose, goes back through the sinus this way down toward the throat. That's why it's shaped like that. So it can go up and down and in, also known as a nose trumpet, so that we have a direct flow of air from the nose down into the lungs. Contraindications, meaning don't use this if there is any damage to the maxillofacial region right here. If the nose, the upper lip, if any of this is busted up and broken, don't use it. If the bone structure and cartilage structure of the nose is compromised, the nasopharyngeal airway is going to go up, or could go up, not down. We want it to go down. Also, if there's any clear liquid, viscous liquid draining from the nose, that's a strong indication of a traumatic brain injury, and we don't want to use a naso in that instance as well. So clear liquid running from the nose or damage to the nose and mouth region, we don't use a naso. Typically, we're going to put a naso in if we suspect that the casualty could pass out. They're acting like they're going to pass out, okay? We always use the Surgilube that comes with this, the surgical jelly that's on the back of this package. And there's lots of different ways you can apply this Surgilube. The easiest way is rip the package open, take the jelly, open up the jelly like so. By the way, all of this is covered under the Good Samaritan Act, okay? So under the Good Samaritan Act, we don't get to make new holes in people, but we can address existing holes in people. So you don't get to do a field expedient tracheotomy. So you take your surgical jelly, your lube, and smush it into here. I guess I didn't get it all the way open. There we go. Smush it into here like so. There's our jelly. And then I'm just gonna do this with it. Boom. Lubed naso, okay? And this goes up the nose. Typically, because humans are weird, your strong side hand is going to be the same size that you have a larger nostril. Why, I don't know. So if you're right-handed, your right nostril is going to be larger. If you're left-handed, your left nostril is going to be larger. Statistically, approximately 90% of human beings are right-handed. So that means if you don't know, start with the right nostril. And this goes up the nose and in like so. And it comes around back down here to the back of the throat like so. And it gives a clear, patent airway for air to flow in and out. There's other techniques, the chin lift jaw thrust method, the recovery position, both of which are Googleable. You should research those and understand what they are. We also train those in class, Responder 1, Responder 2, Responder 3 from Refuge Training. The naso represents less than 1% of preventable combat injuries, less than 1% of preventable civilian injuries, but it is included in most kits because if you need it, you need it. You have to maintain a patent airway. Oxygen has to flow from the front of the face into the lungs. So that's the airway portion of March, okay? Super cursory here. Our primary concern is going to be to keep the blood inside the body, and then we're worried about airway and respiratory, okay? So airway, being the nasopharyngeal airway, that's what we include with our kits. J-tubes, if you are certified to use J-tubes, oropharyngeal airways, and you're dealing with an unconscious patient, go for it. The beautiful thing about a naso is while it's uncomfortable, it's not enjoyable to have one of those in, which is why I didn't put one on and put one in on camera for you. Nobody likes it. In fact, in class, we offer a $20 bill to any volunteer that wants to have a naso put in. We very rarely hand out $20 bills. But while it is unenjoyable, you can be perfectly conscious and awake and alert and have a naso installed as compared to an oropharyngeal airway. So next is respiratory. Respiratory. This is a chest seal. What we need to understand with a chest seal is start first with what's called the pleural space. Basically neck to navel in this area, what we call the box. 360 degrees around you. This is the pleural space. That space operates in a vacuum. Your diaphragm down here seals off the bottom of that. When your diaphragm pulls down, because the pleural space is in a vacuum, your lungs expand. So when you breathe in, your diaphragm is pulling down, causing your lungs to expand and draw in air through your airway. If you get a hole in your pleural space, front, back, sides, anywhere in between the neck and the navel, you lose that vacuum. You may have heard of a sucking chest wound. What happens is the diaphragm pulls down, but the air takes the pathway of least resistance. Instead of coming through your airway and into your lungs, it goes through the hole in your chest. And so now the lungs aren't filling up with air, which means we're not getting oxygenation. We now have respiratory issues. So this is called a pneumothorax, okay? Well, we'll get into pneumothorax in a moment. When we have a puncture to the pleural space, the way we're gonna deal with that, with this hole right here, and I don't wanna go too deep on this because again, this is information, not instruction. So the cursory efforts that we're going to take here is we're going to open up our chest seal. Again, you see the red tab on the package. Open it up, pull this out. And guys who don't know anything will tell you not to fold these up inside of your kits because that can damage them. That's cute because when you get them, they're folded in half. So that tells me that that person has never been to training when they say things like that. Don't throw this away. We're going to come back to this packaging in a minute. This is a hyphen vented chest seal. And it is super sticky. Okay, it's got these 3 vents. It's kind of shaped like a flux capacitor. These channels are vents. We'll get into that in a moment. It's got, again, this red tab so that we can pull this apart. As you noticed, it comes with a little piece of gauze. We're going to take this gauze at the wound. There's going to be blood, viscous fluid, all of that around the wound. We're going to use this gauze to clean the wound area up so that we have the best likelihood of the chest seal sticking. That's why in our kits, for example, here in the BearFac, what I include in the stack, this is our Airway and Respiratory module in the back of the BearFac. I've got my shears so that I can access injuries to the chest or the legs or whatever, so I can cut clothes off, because I'd rather be alive and humiliated than modest and dead. Okay, so cut the clothing off, get it out of the way. And these are high quality EMT shears from North American Rescue. We've also got a burn tech dressing in here for burns. But here's my nasopharyngeal airway. Here's 2 5x9 gauze pads and a twin pack of high-fin chest seals that come standard in this kit. Why 2? Because you have 2 lungs, left and right. And also, bullets tend to go through things, not in things. And so you have an entry wound and an exit wound, which we'll talk about in a moment. But the reason I'm in this stack is to show you I have 2 5x9 gauze pads in here, big ones. Because I may need more than this little bit of gauze right here to clean this up. So having a big piece of gauze in my airway module helps me a lot with that. So I've got 2 5x9s and 2 chest seals for entry wound, exit wound, or left lung, right lung, okay? So we're gonna clean the wound, get all that stuff off of there, all the schmoo, all the viscous fluid, the blood. If the casualty is conscious, we're going to say to them, exhale, exhale, exhale. And what that does, when they exhale, they blow all the air out of their lungs, and that moves the diaphragm back up, okay? The diaphragm is riding like this inside of the chest cavity, inside of the pleural space. So when they exhale, it's going to move the diaphragm back up. After they exhale, we're going to take this. See how super sticky this is? We're going to take this, peel it off, and we want to orient at least one of these vents in the downward position so that the viscous fluid that's in there can drain. We're going to center the wound in the chest seal here like so. I'm going to apply it like so. Smooth it over. Try and maintain those vents like so. And there you go. Now, when the casualty breathes in, this becomes a one-way valve. When they breathe in, this sucks closed, and it closes up, and it maintains the vacuum in the pleural space. When they exhale, when they breathe out, that lets go, and any gases, viscous fluid, back pressure in the pleural space will drain out of these vents, okay? Now, oftentimes, the casualty is gonna lay down, or they may already be laying down. So if they lay down, we wanna lay them down in such a way that the vent is now oriented downward so that gravity can do its work and can drain away that viscous fluid, okay? So super simple. Punctures to the pleural space, we apply chest seals to reestablish the vacuum of the pleural space so that the lungs can work when the diaphragm goes up and down, so the lungs fill up, okay? Now, I had an exit wound here. What about the entry wound? What are we gonna do? I only had 1 chest seal. This is why I have a problem with the standard issue US military individual first aid kits, because they come with this exact 1 chest seal. Well, I've got 2 lungs and I've got an innie hole and an outie hole. Now what do? That's why when we built the BearFac, that's a far superior individual first aid kit, we've got 2 high fins. 1 for the in hole, 1 for the out hole. What if you don't, or what if you don't, excuse me, or what if you don't have a chest seal in the first place? any occlusive material, this piece of plastic here, this piece of plastic here, this piece of plastic. In Vietnam, they were using the cellophane off of cigarette packs to do this. This piece of plastic, any of this will work. Let me show you how. Super simple. I'm gonna take my tape I've got here. I'm gonna get 3 pieces of tape, like so. This is good high quality surgical tape. And the wind is not cooperating. See, that shows you how good it is. The wind is not cooperating, but that's okay. Life is an adventure, right? Get my surgical tape. I get my occlusive dressing. I'm gonna cover this. I'm gonna tape over 3 sides, not 4. Why not 4? I'll show you in a moment, okay? So I'm gonna tape over 3 sides, like so. Now I've got a one-way valve. And you may, in many cases, you may have to back this up with a pressure bandage or have somebody tend this casualty and hold a hand over this. When they breathe in, it closes up. When they exhale, it opens up. One-way valve again. Now, why 3 sides and only 4? Because when this happens, when we apply a chest seal, we are going to induce a tension pneumothorax. We're going to create pressure in the pleural space that begins to collapse the lung. Between 5 and 15 minutes, the casualty is going to start going into respiratory distress after you put a chest seal on. That means after you put a chest seal on somebody, ideally you need to stay with them, or you need to designate somebody to stay with them and monitor them, because they're going to go into respiratory distress. And people who can't breathe will tell you they can't breathe, whether it's verbally, or they become agitated and anxious, or they're clawing at their throat, they will tell you they can't breathe. And what's happening is the back pressure created by the wound in the pleural space is collapsing the lung. We need to release that back pressure. We cause this problem when we put the chest seal on. We can fix this problem by burping the chest seal. And so the way we do that is, again, we're gonna tell them to exhale. We're gonna grab the red tab, and we're gonna, you see how sticky that is, bro? And we're gonna pull up past the wound. And when we get to this point right here, oftentimes you'll hear an audible right here, and that back pressure will blow out. Then you tell them again, exhale, exhale, exhale. Then you close it back up. Now check this out. I did that. What happened to my vent? Compromised my vent. That's why there's 3 vents here. Okay, I may have to now orient the casualty in a different position because this vent is now compromised, and I need that pressure in that back fluid, or the back pressure in the fluid. It has to run away. That's why we use vented chest seals. What about this one that we improvised? Same thing. That's why we leave this corner open, because we're going to tell them exhale, 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 and then put it back down. And you may need to apply more tape. Okay, so this is an improvised occlusive dressing. This plastic will work. It's not as good as this Mylar, actually. So you do the same thing with the Mylar. You can leave it like this, or you can split it down the middle, like so. Tape this up, like so. Do the same thing. All right, buddy. Yeah, all right, you're going into respiratory distress. Okay, hold on. We're going to burp the chest seal. All right, exhale, exhale, exhale. Put it back on, tape it back down, reapply the pressure dressing, whatever you may need to do. Now, at this point, with this type of pneumothorax, we created the problem. We're not going to fix the problem with a needle decompression. Needle decompression is not covered under the Good Samaritan Act. And as of 2019, I am unable to teach needle decompression to you unless you have funny letters after your name. There is a channel, Skinny Medic, Medical Gear Outfitters, has a video that's about 8 years old now that covers needle decompression. It's on YouTube. If you want more information on that, you can go check that out. But I cannot legally teach it to you unless you are a certified medical professional. So, Needle decompression is a subject for a different time. We cover all of this at Refuge Training, and you should go to Refuge Training and find a class near you, or go to anybody else's training class and figure out how to do this stuff. But it's super simple. We want to cover the holes in the pleural space so that we can reestablish the vacuum for the diaphragm to work in, so that when the diaphragm pulls down in a vacuum, the lungs expand and bring in air. If we're not bringing in air, we're not oxygenating the blood, we go into cell death and people start dying. So it's a super basic concept. We go far deeper in class with a simple pneumothorax, a tension pneumothorax, an open pneumothorax, what all of that looks like, the whole nine. I'm not going to get into that here on this channel on this content. But if you're dealing with somebody who's been involved in a car wreck or an active shooter situation or a workplace injury where they've had a puncture to the pleural space, this is how you treat that. By applying chest seals over it, monitoring them for respiratory distress, burping the chest seal as needed, and we're always going to be elevating to a higher level of care. We're going to call 911 immediately once we start rendering aid, telling them what's our location, what is the methodology of the injury, how many ambulances to send, what aid we've already rendered, what we're wearing, where we're located on the X, where we are, what type of vehicle we're driving if we're in a vehicle, relaying all that information as clearly and concisely and calmly as we can to the dispatcher so that they can roll the appropriate first responders to the scene so that they can intervene and elevate to a higher level of care. We're buying time for these people that we're rendering aid to. So chest seals, super simple. That's Airway and Respiratory, episode 4 of the March algorithm. Please share this with people that you know that need to see this. I want to save as many people's lives as possible. And also, please do not confuse information and instruction. This is informational only. You need instruction. You have to come to class and do this with your hands and understand the science behind it, and do it until you fail so that you can be taught to do it better, so that when it matters, you won't fail in real life. It's super important, guys. I appreciate y'all very much. Y'all have a blessed day. Shalom.